This is an audio recording of the CCLD webinar hosted on April 21st, 2021 regarding further guidance on visitation, outings, dining, and social activities in reference to PIN 21-17-ASC.
As Dr. Aronson said, my name is Kevin Gaines, and I'm Deputy Director for the Community Care Licensing Division in the Department of Social Services here at the State of California. Just wanted to give a couple opening remarks. First, thank you for taking the time to join us once again for this, our 18th informational call for adult and senior care licensees and facilities. We understand how busy you are. And we really appreciate the time that you take to participate in these conversations. Your time is valuable, we know, and we continue to recognize the important and hypercritical work that you're doing to maintain the health and safety of the folks that are in your custody and care. We know that you and your staff remain on the front lines, and we know your commitment to making sure that folks are safe. And the well-being is the best possible. We share that commitment with you, and this and the other 17 conversations that we've had are just part and parcel of that effort to maintain the team and to work together as much as possible to make sure that our collective goals are realized. So today's call, just as powerful as the last one. It's going to provide you further guidance and answer your questions on visitation, outings, dining, social activities, all of these elements that are outlined in the PIN that we released a few weeks ago. The number for that one is 21-17-ASC. And we're reviewing that. We reviewed that on the March 26th call. We know you have additional questions. We're going to help answer some of those questions. In addition, we're going to provide an overview of what's included in the new ADP PIN. That number is 21-21-ASC. That addresses our support for adult day programs to operate during this pandemic and provides information on COVID-19 vaccinations. By the way, I want to make sure that you hear it loud and clear from a representative of the department that we're encouraging everyone to get a COVID-19 vaccine as soon as humanly possible. That's the only way. Widespread vaccination in state, worldwide. That's the only way that we're going to make a dent in this pandemic. So get to it as quickly as you can. One more thing, we released another PIN last week on April 15th. The number for that one is 21-20-ASC. This one provides some important information to you about how licensees, facility staff, residents can access COVID-19 vaccines in light of the ending of the federal pharmacy partnership for long-term care. This PIN further highlights current vaccine information, how to schedule vaccine appointments, additional resources that you may need to support you as you in your facilities access those vaccines. So I'm going to stop talking now and get out of the way. I'll bring up Vicki Smith. She's our Adult and Senior Care Program Administrator for CCL, and she's going to introduce our panel for today's call. Again, thank you so much for attending, and enjoy the call.
Great. Thank you so much, Kevin, and thanks for being able to join us today. And to all of you that are on the call, welcome once again. I'm Vicki Smith. As Kevin mentioned, I'm the statewide program administrator for the Adult and Senior Care Program here at Community Care Licensing. I just really appreciate all of you carving out some time in your day. I know your schedules are busy as well, and I appreciate you carving out that time to join us for another one of our informational calls. Today we're also joined by two seasoned veterans, and that's Dr. Louise Aronson and Josh Allen. Dr. Aronson is a professor for the Division of Geriatrics at the University of California, San Francisco, and Josh Allen is a nurse and a principal with the Alan Flores Consulting Group. Also joining us today will be some folks from our policy shop here at Community Care Licensing that specialize in adult and senior care policy, and we'll be able to provide further clarifications on PINs as we kind of move along through the Q&A as well. So we can advance to slide 3 together. So today's objectives, as Kevin mentioned earlier, we'll take a further look into our recently issued PIN on visitation, outings, and dining, PIN 2117-ASC. If you haven't had a chance to take a look at that yet, feel free to grab it off of our website. It answers some questions related to recent guidance on visitation, outings, dining, and social activities. So we'll take a little look at that and try to provide more clarification today on that PIN. Also, if you'd like to join along with the presentation, I see that I think the highest numbered Q&A right now is, can somebody send us the PowerPoint? So I don't know if someone on the call that's helping us facilitate the call today can plop that into the Q&A so folks can get a direct link. But if not, if you go
we have put it in.
Oh, perfect. Thank you.
It's in there a few times.
Perfect. Thanks so much. If you haven't already received it or you're having problems with the link, if you go to our CCLD website, ccld.ca.gov, when you're there, click on COVID-19 information and resources, then go down to additional resources, and then click on information calls, and you'll be able to access the slides today. And those will remain on that site, so if you can't grab them now, they'll be there ongoing. We're continuing efforts to make the recordings of these calls available, so please be patient with us and continue to check our COVID-19 information and resources page for updates on our hosting of the recordings for these calls as well. So with that being said, I will turn it over to Dr. Aronson so that she can facilitate us through our call today. And again, thanks everyone.
Terrific. I actually think we're going to start with Josh Allen, and then I will be back in just a minute, and we'll do our usual rotation. I see that there are lots of questions about all these different aspects, so please heads up, because we're going to answer a bunch of the questions in the chat now as we go through the first few slides. So over to Josh.
Thanks, Dr. Aronson. As we sort of continue to our next phase of COVID response, as we're looking to reestablish some of the activities and outings and dining and different things that are such an important part of our residents' lives, it has created lots of questions. When we did our last webinar, we literally ran out of time, and so one of the things as Vicki was just explaining, we're really hoping to do today is to hit on as many of those frequently asked questions as possible. A lot of the questions I'm seeing in the Q&A we're about to answer, so it's a good thing that these are obviously questions people have. Next slide, please. A reminder, as always, when in doubt, you want to follow the strictest requirement. And that's something we've been saying for a year now, as we've had these various PINs, recommendations coming from the department, coming from public health, coming from even the CDC. As a general rule of thumb, you want to follow the guidance that is the most stringent. Right now, we're obviously seeing, the majority of the states sort of reopening. We're seeing a lot of expansion of services and in the public, things that are available. So we're not, I don't think we're dealing with this as much as we were maybe a few months ago, where counties had, certain requirements that differed from what you were seeing in the PINs. But nevertheless, when in doubt, you do want to follow that strictest requirement, and you can always reach out to your regional DSS CCL office if you need clarification. Next slide, please. So let's talk about visitation. This was one of the big steps we took in the last few weeks, is really reestablishing a more normal and routine visitation experience. We've been doing all sorts of alternative visitations with designated visiting areas and outdoor visitation and window visits and all these things, virtual visits throughout the pandemic. But we are now at a point that every facility across the state should really be ensuring that visits are accessible to our residents at all times, and those visits include going in the resident's apartment. Next slide. So as we do that, lots of questions come up, and these are some of the more common ones. We generally include in visitors, we include our volunteers, entertainers, the folks that participate in our activity programming. So they've been coming back into our facilities as well. And one of the questions we get quite a bit is, what type of personal protective equipment do they need to wear? The most common question that we hear is, can singers take off their masks? Because understandably, it's a little bit harder to hear someone sing when they're wearing a mask. The short answer is no. We expect our volunteers, entertainers, singers, and so forth, we expect them to use the same personal protective equipment that we are expecting of all of our visitors. That would include, at a minimum, a mask or cloth face covering anytime that they are in the facility. Second very common question, and I know Dr. Aronson's going to talk a little bit more about dining in just a moment, but one of the things we're asked quite often, and again I see it in the Q&A, is can the visitors come into the dining room and enjoy a meal with the resident? At this time, we are not recommending that. And the reason behind that is, I think, two things. Number one, our dining room is a communal setting. In that dining room, we have other residents, and so if they're sharing that space with visitors, obviously when we eat, the masks have to come off. There are some concerns that are we potentially exposing residents unwillingly to the risk of exposure to a visitor. We realize that's frustrating, particularly with Mother's Day coming up, and I think we'll get more into that in a little bit. We know that there's a big push that people want to dine together. We understand that. It's really just not appropriate in the dining room right now. There are certainly a variety of alternatives that we can contemplate, particularly with Mother's Day around the corner. For example, residents could dine in their apartment with their visitor. We would still recommend they stay 6 feet apart. We would recommend they only remove the mask to eat, and then it immediately comes back on. Another good alternative might be to set up some dining options outdoors, where we know the risk of COVID transmission is much lower in that outdoor environment with air circulation, sunlight, and so forth. So I think, if we're a little bit creative, we can do some really great things to accommodate the desire to dine together, particularly with Mother's Day coming up. But really, it's not appropriate to do that in the communal indoor dining room just yet. And we're getting close, but we're not quite there. People will often come back and say, okay, well, what if the visitor is vaccinated? And at this point, we're still saying same answer. We don't want visitors coming into the dining room quite yet. I also think it's important to remember, and I know this doesn't necessarily make it easier, but we're a long way from where we were even just 3 or 4 weeks ago, in terms of the options for dining and outings and visitors and a variety of things. And we know everyone is eager to get back to normal, back to what it was pre-COVID. It's just, we're going to continue to cautiously move in that direction with a focus on balancing safety with quality of life. Can visitors stay overnight? Yes, they can. If they're going to do that, we just need to make sure they're going to follow our request to not have contact with other residents and, of course, minimize contact with staff. So one of the things we get a little worried about is if someone stays overnight, are they going to be able to stay in the resident's room or apartment the entire time? And that's just going to, I think, depend on the situation and the individual, but we would need to make that very clear with them. Can unvaccinated residents be visited by their loved ones indoors? Yes. What about in their room or apartment? Yes. Regardless of vaccination status, all residents should be allowed to have visitors visit indoors, including in their room or apartment. Really the only exception to that, of course, would be if the resident has active COVID and is requiring isolation. Otherwise, yes, they can have those visitors indoors, they can have them in their room. Keeping in mind, we do still ask that visitors avoid physical contact with the resident unless both the resident and visitor are vaccinated. Next slide. Outings. For a very long time, for almost about a full year, our residents, our entire country, our entire world, including our residents, obviously had a lot of limits on outings. Lots of places weren't open, and we were really discouraging residents from going out. Now, residents always have the right to leave. As much as I hate to have to say this, we all know we don't operate prisons. They have the right to go. But at different points during the pandemic, if they went out, there would have been the requirement for possibly quarantine, possibly testing, kind of depending on the situation. Next slide, please. We now know from the latest PIN that our residents can go out, and as long as they are not exposed to COVID during their outing, when they return, they are not required to quarantine or be tested. So our residents can go, they can take advantage of whatever is open in your area, which right now is lots of things. We still ask them to wear a mask. We still ask them to practice social distancing. We ask them to wash their hands. When they return, we're going to screen them for exposure, but they do not generally have to be quarantined. So some questions that come up. Number one, can a resident leave for the day with an unvaccinated loved one? The answer is yes. Regardless of the loved one's vaccination status, the resident is allowed to go with them on an outing. Again, we would encourage and request that they wear a face covering and practice social distancing. Number two, do residents need to quarantine when they return from an outing? No, they do not. As long as we screen them when they return, like we do anyone entering our community, to ensure that they don't have any symptoms of COVID, obviously, and that they were not exposed to COVID while they were out of the community. Otherwise, no, they do not need to quarantine. Do residents need to be 6 feet apart when we take a group of residents out for a drive? Yes, that is the recommendation. If we are taking residents on an outing using a community vehicle, whatever that vehicle might be, we still want to encourage social distancing as much as possible during that drive. Can we take a group of residents out to a local park? And there is a variety of kind of variations on that question. Can we take them to a park? Can we take them to a store? Can we take them, to different services and so forth in our area? The short answer is yes. Just like they could go on their own or they could go with a loved one, we can take them as part of our transportation program. Again, while we are out, we would ask that they wear a mask. We would ask that they practice social distancing. And I would argue there's probably a better chance your resident's going to stay compliant with that mask the entire time when you're with them, as opposed to going on their own or with family. And with that, I'll flip it over to Dr. Aronson, who's going to talk about dining and activities.
Thank you. So lots of questions about this in the chat, and so hopefully we will answer some of them. Next slide, please. Okay, can we stop using disposable plates and utensils? Yes, that was an easy one. Hopefully a good answer for all of you. Can residents dine together less than 6 feet apart? Yes, and I see in the chat there are all kinds of questions about, does that mean 3 feet? How many people per table? And I'm going to, no pun intended, table that until the discussion, because I want some of the CDSS policy people to weigh in on that, in what it means less than 6 feet apart. What are the parameters that we would ideally follow? Do wait staff have to wear masks when serving in the dining room? Yes, this is akin to many of the questions in the Q&A also about, if singers are fully vaccinated, do they have to wear masks? If other people are fully vaccinated, we realize that this is difficult and stressful and sometimes incomprehensible in a setting of high vaccination. And you all have far more leeway than they do in other settings, and we anticipate that will be more so unless the variants and the double variants bring trouble, and it's still unclear whether or not that will happen. All right, so masks, yes, everyone in the facility should be masked except for a resident in their room by themselves. How should residents store their masks when eating? There are a variety of approaches to this, but kind of the way the rest of us do. If you've been out to eat at this point, which I assume is sort of in your lap, under your napkin, in your purse, in your pocket, wherever, I will have to say that as a woman, sometimes when you go places, they'll have a little hook under the table where you can put your purse, and that could be an idea, but you would want to make sure, I've heard this from a couple of people now also, that it's not a metal hook that's going to cause a wound on the person's leg, because remember, older skin is more fragile. You'd want something plastic off to the side near the leg of the table where a person would be anyway, if you want to go that route, but you'd probably be better off just having them tuck it under their legs. Can non-vaccinated residents participate in dining and activities? Absolutely. You are not allowed to discriminate based on vaccination status. I realize there are parts of the world in which this is happening, but we are not living in that part of the world. So no discrimination is allowed based on vaccination status. Next slide, please. So now we're going to discuss screening and testing. Next slide. And just before we go there, a quick reminder of when you might want to be considering testing. It actually hasn't changed, but we're sort of in this new world, so it probably warrants reminding. So symptoms that are more common with COVID-19 than with allergies: fever and chills. You should not have fever and chills with allergies. Muscle and body aches. Some people do occasionally get some joint pains or aches from very severe allergies, but for most people this is a non-issue. New loss of taste or smell. Nausea or vomiting. Diarrhea. Weakness and confusion. So all those things, you're much more concerned about COVID-19 or another serious illness than you are about allergies. Symptoms you can see for both: cough, shortness of breath, although, I think that would be if your allergies are related to your asthma, more so than allergies alone. When people say shortness of breath from allergies, it usually has to do with nasal congestion rather than the inability to breathe in and out through your mouth. Having trouble breathing in and out through your mouth is always something of concern. Fatigue, headache, sore throat, and congestion or runny nose, obviously, for allergies. Symptoms more common with allergies: itchy or watery eyes and lots of sneezing. Next slide, please. Common testing and screening questions. Can we stop surveillance testing? I've seen this a lot in the Q&A as well. No. You can't at this point. I think we explained this last time. I realize it's frustrating if you have a really high or perfect vaccination rate. The reason is we don't yet know what's happening with the variants, and we don't yet know how at risk unvaccinated, mostly staff, but sometimes residents are, We don't know the impact of unvaccinated visitors. It is increasingly looking like people who are fully vaccinated are less likely to be asymptomatic carriers and therefore spread the disease. But even that isn't sure, and it may be variant dependent. So we realize this is burdensome and costly, and hopefully the world is going to continue to change in ways that this will stop in the not too distant future. Can you require visitors to be tested? You cannot. You can't require. You can't require testing. You can require mask wearing and answering of questions, but not testing. How long should you keep screening records? Probably for residents and staff, you want to do it in accordance with normal record requirements, so at least 3 years. For visitors, it's not entirely clear. We're sort of suggesting 90 days. It may depend how often people are coming, but generally at about 90 days, just because they screened negative before doesn't mean you don't have to screen them again. And the idea is really like if there were an outbreak, you would look back and see who'd been there. But once it's been 3 months, probably that information isn't so helpful. How should I handle staff and residents who are fully vaccinated yet test positive? So this is a really important one. They still need to be isolated. So if a positive test is a new positive test, then you treat it as a positive test, as we always did. So staff would be excluded from work for 10 days from the test date. Then it would depend on whether or not they are symptomatic. There is actually a new PIN 2123 that you can find on the website today, which goes into this in some detail. But you do need to isolate people, and for staff, they do need to be excluded from work. This is except for during critical staffing shortages, as before, when they can work with and only with people with COVID-19, residents with COVID-19. Is it okay to ask to see a visitor's vaccination card? You don't necessarily need to do this, but if the visitor wants to have physical touch with the resident, then you need to see their vaccination card. On the other hand, you can't require them to show it, but you could say, look, I can't let you do physical touch unless I see that you are indeed truly fully vaccinated. In other words, 2 weeks from their second shot, or from their initial shot if J&J, though that's on hold now. Do we need to scan a visitor's vaccination card? You don't have to, but it does make subsequent visits easier. I say this as a daughter from experience, so I recommend if you're going to show it, let them scan it, and it's much faster getting in the next time you go to visit. Next. So now we're going to move to questions about assisted living facilities and board and cares. I saw something in the chat, in the Q&A also, about when will we get to the ADPs, the adult day programs. We will save, depending on how we're doing with questions, the bulk of the attendees tend to be from the facilities community, so we're going to spend the bulk of the time on that, but in the last half hour we will get to the ADPs, and we will also have time for questions from them then. If you are on phone only and want to text us a question, you can do so at 22333. When you do have to pay carrier rates. If you have additional questions after this session, you can contact the Adult and Senior Care Office, and we have been putting in the Q&A and chat links to our short survey. So just a reminder to fill that out at some point after this session, if you would. And with that, we can stop the slides for now and move to answering some questions. And if our panel would join me. I will start with the top question, which is something I just discussed, but I don't know if somebody on the CDSS end or Josh have ideas about when this might happen. When might we see a reduction in testing requirements based on vaccination status, right? So now it's kind of a universal requirement for some scientifically good reasons. And then there's the second part of the question, will loosening of visitation occur based on vaccination allow visitors to join dining? Okay, so two separate questions. Let's start with the first one. Will a community's vaccination status ever impact testing requirements going forward?
Why don't I take that one on behalf of the department? We are updating testing cadence for facilities based on a certain threshold of vaccination for residents, and we haven't released that just yet. It's in the works. We hope to get that out quickly. So I would continue to look over this next week. I think that it's also important for folks to, I'm very proud of actually the department and being very mindful that personal rights is the utmost protection in trying to balance out our guidance with ensuring that folks that have made the informed decision to not get the vaccination or who couldn't receive the vaccination also have their rights respected. So we take all of those things into consideration in updating the PINs and the testing cadence and the vaccination thresholds. But yes, we are working on something and hope to have something coming down the chute rather quickly.
Okay, and the second part of the question was really like, will there be any changes that would allow vaccinated visitors to dine with vaccinated residents, which would be slightly different since everybody would be at lower risk?
Yeah, I'm going to give you my interpretation of our PIN based on that question. And I think the difficulty here is that when you have 14,000 facilities, every single one has a different kind of a layout, right? We've got the smaller 6-bed where there might just be one dining table up to a little bit larger that has multiple dining tables. Then we have inside versus outside dining. So I think if you look down the structure, there is the allowance now, right? When you have two fully vaccinated parties, you have personal touch that can occur. And so now the issue is, where is that dining taking place? Outdoors would be one thing. Indoor, the issue is that if you're in a communal setting, there's potential risk to other residents and not just the resident that you're having the initial contact with or the dining with. So I think it really, there are some nuances that are so varied that it's one of those that I think if a facility really has a question, they really do need to reach out to the local regional office and kind of walk it through specific to that facility. But Josh, did you have anything to add on that? Or even Lilith, I know Lilith from our policy team's on the line as well.
Yeah, I definitely agree with always, when in doubt, reach out to your LPA. And that's been a really great resource for us throughout all of this. That, as Vicki said, these are recommendations that are being written as best as possible to apply to, thousands of facilities. And there are a lot of variations that are not always going to, fit neatly into one document. So I think definitely when in doubt, pick up the phone, open up your email, reach out to your LPA, and we've had a lot of success doing that. I also think I stopped trying to predict the future of COVID a long time ago. So when are things going to happen? I don't think anyone can say for sure. When are we going to stop wearing masks? When are we going to stop testing? When are we going to stop all of these various things? No one really knows for certain. It's literally a day by day, looking at the numbers, looking at the cases, looking at what's happening with vaccination, and working it out as we go along. Because whether it's all of us on this call or all the way up to the CDC, no one can say for certain what COVID will look like next week or next month. I think, as was mentioned at the beginning of this call, keep pushing for vaccination, because that's our best hope for making all these things happen. Whether it's visitors or testing or any of this, getting people vaccinated is what's going to get us there.
Yeah, and I want to add a little bit to that, because some people are saying, well, if everybody's vaccinated and some of these things still aren't changing, that's frustrating and sometimes confusing to people. So I think we have to acknowledge that, yes, it's true, because if we're in certain other situations where everybody's vaccinated, other things are permitted. And the reason it's a little different here is actually severalfold. One is that people are at higher risk. Two is there's an oversight responsibility for the welfare of vulnerable others. And the third is that when you can make a conscious decision, like, yes, people are doing all sorts of things, and in some places that's leading to more deaths and a surge, and actually the creation of more of these variants. So just because a person can doesn't mean they should. And so what we're trying to do here is sort of ascertain the context. And the more we can get staff, residents, visitors, families vaccinated, the more likely we are to live in a community and state where we can actually open up in all these ways we are all so hungry for. Little change here to can we require vaccination for new admissions prior to admitting a new resident? Want to take the requirement?
I'm sorry, Dr. Aronson. I was reading questions in the Q&A.
It's very hard to do both at once, isn't it? I find it virtually impossible, but thank you for trying. Can we require vaccination for new admissions prior to admitting a new resident?
I'd love to hear the department's take on this. I had this conversation recently with Joel Goldman, one of the most respected attorneys in our business, and the short answer is it's a little bit of a gray area. Residents, for example, have the right to refuse medical care. That's one of the residents' rights. And so I think it starts to get a little confusing. Are we now attempting to mandate medical care for that resident? So I think the short answer is it's not entirely clear. Fortunately, the residents in overwhelming numbers are participating in vaccination, at least in senior care facilities. So I don't know that this is as much of an issue for us as maybe we thought it would be.
And they're used to things like PPD and other recommended things. But yeah, most people seem to really want it. Anything from CDSS that differs from what we just said?
Sure. I'll put it out in kind of maybe some perspective is that someone exercising their personal right to not obtain the vaccination is not grounds for a denial of admission on its own. If there was a denial of admission, then it should be based on something other than just vaccination or failure to vaccinate. And that would go back to your plan of operation, your admission agreement, those kinds of things that are on file with the department.
Great. I want to acknowledge that there are a lot of day program questions that are very high on the list, and I'm skipping them for now, but you are not forgotten. We will come back to you in the next session. Next highest one, are performers allowed to be indoors? Yes. And should they have vaccine proof? So we are treating performers as we're treating any other visitors. You must screen them. They must wear a mask. They must be at distance. All those things. So treat them as you treat all visitors. So with that caution, but they are allowed to perform indoors at this point. Okay. This is an interesting one. So why were individuals, so for adult programs more than senior here, I think, why were individuals allowed to attend group employment sites but not participate in one-to-one visits or 1-to-3 ratio activities through day programs? How is that different than a group of individuals working in a supported employment role? So this can be people going out to work, people doing day programs as well as living in facilities. Any answers?
I'll answer for the department. That's an interesting question. The department doesn't license supported living providers. It does license adult day programs. The department did not issue anything that ceased operations for adult day programs. So it almost might be a question that would be better for the funder of the program, which I'm assuming is probably one of the regional centers. There was nothing on the licensing side that would have differentiated whether someone would participate in one or the other. Both of them were, I'm not sure if SLS services had been ceased or discontinued, but ADP services were not discontinued by the department. So I think it's a question probably better for the regional center.
And I think it also speaks to the fact that sometimes we have different organizations or different situations. A resident in an assisted living environment now could go out and, in most communities in California, they could have a meal with some other people, and yet that's not happening in the facility. Part of that is because the facility environment is different and the people in it are at higher risk. And the general protective situation. But the fact that you're seeing some things that feel like inconsistencies, I think that's because this is all new and all evolving. And just know that everybody's trying to be thoughtful and do their best, but sometimes very reasonable people can come to, slightly different conclusions based on the same data. But hopefully, as we all get vaccinated and things get better, we all move to the same good place together. So there are a lot of questions about the social distancing requirements for sort of three different situations: dining, transportation, and activities. And we've been talking about some clarification there, and I don't know if Vicki, you want to take that one as well?
I can take that one, Vicki.
Thanks, Lila. I was just going to toss it to you.
Okay, hi everybody. My name is Lilith, and I'm a member of the policy team here at CCL. So clarification about the dining and activities, and then maybe transportation after that. It's a little different. And I think we touched on, the dining and the transportation a little bit, in that we are cognizant that it's difficult to maintain that distance. So we have indicated that if residents are eating at the same table and they are not able to maintain that distance, that's okay. But there are some kind of cautionary things that we want them to consider. So, for example, cohorting certain groups of residents together so they can kind of dine together, throughout each day. And also having them practice appropriate hygiene, and then keeping their masks on if they're not, actively eating. We're still wanting to encourage distancing between different tables. So if you can keep them at 6 feet apart, I think that's something that we would still continue to recommend. And the same kind of would apply to activities. So they could still remain within the 6 feet. But again, the mask, and then try to cohort them as much as possible, et cetera. And I think we touched on the transportation issue a little bit as well. So again, recommending the 6 feet distancing. It does become difficult, if you don't have a big bus where you can kind of keep that apart. But, lowering windows and all that, and I can defer to Dr. Aronson and Josh too, probably on some other pointers on how to safely do that. But we don't have any updated guidance on transportation that would really indicate something different.
I also think, with all of that, try to use some common sense. I don't think anyone is we all realize that you're operating in the real world. It's real easy to sit here at a desk and say, stay 6 feet apart. You've got a group of residents, that's easier said than done. And I don't think anyone's trying to suggest that, you're going to break out a tape measure and make sure no one gets within less than 6 feet on a bus or something like that. But, avoid large crowds. Don't get residents into large groups if you don't have to. I saw a question earlier in the chat, how many people can sit at a table that accommodates 8? I would say keep it to as few as you reasonably can. So the table might be able to accommodate 8, but maybe we could put 4, and people would still be happy and enjoying their meal, but we wouldn't quite be shoulder to shoulder. We've talked so much about 6 feet in the last year, and that is the guideline. But again, it's really about let's keep big groups to a minimum. Let's try to keep people spaced apart. We realize your residents live together, particularly in the smaller RCFDs, literally living in a home together, and recognize it's not always as perfect as we might describe it. But I think we do our best. We try to encourage people to keep their distance, and recognize it's not always going to be perfect.
Great, thank you. you both. So here's a question that brings up the issue of travel, sort of a specific issue and a general issue. What is the protocol? Bounce. There it is. What is the protocol for a resident that is considering joining their family on a cruise to Mexico? Is that allowed, and what do we as a facility need to do before accepting the resident back to the facility? Let me just say that on the CDC website, they have a list of, actually I can show you, I think. They have COVID-19 travel recommendations by destination. And different countries are ranked from most dangerous to least dangerous with COVID-19 risk. So level 4, sort of our purple level, COVID-19 risk very high, the red is high, the orange is moderate, this color scheme we're used to. Mexico is on the very high list, so Mexico is not a great choice for a destination. In terms of is a resident allowed, yes, and they are not incarcerated, but certainly if they go to a high-risk area, I think it would be within your rights to quarantine and test. I'm wondering what others would say about the length of the quarantine and whether a testing at 5 days would make a difference, or whether we're not ready to speak to that yet.
So, yeah, it's a great question, and I think if you work your way through Pen 2117, which I happen to have in front of me, so on page 9 under section D, where it has residents returning from outings, there is a section that has to do with when a resident, because we don't consider where someone's going on the outing necessarily, right? It's kind of silent on that issue. So then the issue is whether the person comes back either asymptomatic or symptomatic, if they've been exposed or they've not been exposed. And I think that the interpretation for that question would actually trigger the paragraph that actually talks about if they're asymptomatic. It talks about if you're asymptomatic, you had no contact, or the contact's been with less than 3 people in an indoor space, right? So clearly on a cruise ship in going to Mexico, whether it's going to Mexico or anywhere else, quite frankly, is that you're in an enclosed space or in space with more than 3 households, is that it would trigger that need to then quarantine for the 14-day period that's outlined in Pen 2117. So a long-winded answer to maybe as you walk through these pens, kind of thinking of those things, is that I would interpret the answer to that question is that yes, somebody coming back, whether asymptomatic or symptomatic, actually would trigger the quarantine for the 14 days.
That makes good sense to me. So quarantine, but it also may be worth telling people about the relative risk.
Yes.
Of going to different countries, because I am finding that, in facilities and in the real world, people are not aware of this website. I can share my screen here and show you what it looks like. So CDC travel recommendations by destination, and then you see the world map, but also you can click on each one or scroll down and you'll see different countries on different lists. And Mexico is here somewhere. There's Mexico. So that's really helpful in helping people pick safe alternatives, although they need to quarantine regardless. But hopefully they won't use that as a reason to go somewhere unsafe with their family. Okay. So question here, overnight home visits, what are the proper procedures? Take that.
Residents, as spelled out in PIN 2117, residents can go on an outing with a family member, including overnight. In fact, I'm pretty sure the PIN actually says overnight, if I remember correctly.
I think so,
so yeah, they're treated the same as any other outing. Upon encourage them to wear their mask and socially distance, avoid crowds, and upon return, we would screen them for symptoms or exposure. And as long as they clear that screening, they would not be quarantined.
Okay. Another really interesting question. What does the governor's June 15th date mean to CCRCs, RCFEs? I have a guess, but I don't know if Vicki, you want to take that one.
I apologize. Would you repeat the question?
What does the governor's June 15th date for massive opening mean to CCRCs and RCFEs?
Yeah, that's a great question. I don't know that we have a definitive answer at this point.
Say that
seems to be
falls back into that trying to predict the future thing. June 15th feels like it's forever away right now. For whatever it's worth, I can tell you in other states that have that we work in that have lifted mask mandates, for example, for the public, they are still in place in our communities. So there's usually a lot of fine print in those mask mandates.
There is discussion that will be the date potentially where instead of having the color tiered system of the yellow, orange, red, and purple, that it will move to a after the blueprint almost kind of system where it will be based on vaccination rate. But what that means for implementation, we're just not quite clear yet.
And I've also heard that it might have to do with vaccination rate plus case rates, some equation of that. So that's obviously complicated and novel, and we're all waiting to hear what the people who think about such things think about. So a very different question. How about opening nail and hair salons for RCFEs? So that is okay now using the same visitor guidelines. So that's a general principle. Many of these were open prior to the latest huge surge over the holidays, and so following the same rules, they can reopen again. There really are a lot of day program questions, and as some astute person pointed out, a lot of day program people have come on this time, so we'll try and get through a few other things for facilities, and then maybe we will move to day programs and give them a chance to ask all their questions. There's a question here about how many residents should ride together in a community shuttle bus. This is sort of what we were discussing earlier, that the ideal is to keep 6 feet of separation, but we also recognize that this is the real world. Other things that can mitigate include vaccination status, really careful hygiene before getting in and after getting out, really good ventilation with open windows during the journey, although the length of the journey may make a difference as well, but you want to try and keep that social distancing going to the greatest extent possible. All right, China in the dining room, yes indeed, you can use that. This is an interesting one I hadn't thought about. Do we need to quarantine fully vaccinated staff coming from other countries?
So, my take on that would be to return to the U.S. from another country. I guess it depends a bit on your mode of transportation, but generally for international travel, you're tested as part of the process to return. And the CDC is pretty clear in their guidance for long-term care staff that if they are fully vaccinated, they do not have to be quarantined following an exposure to COVID. So that's what we've been working off of, is as long as they're fully vaccinated, we would not require a quarantine. Hopefully Vicki agrees.
I was pausing for that very reason. Thinking it through. So far, so good? All right. So this is a question from somebody who works in a CCRC. So the question is, can visitors stay overnight in the independent living residence apartments?
Yes. They could in the AO apartments too.
Yeah. Cannot go to the dining room yet, though, but they can stay overnight in the apartment. Okay. So a couple of interesting questions about visits again. One is there a time limit on the duration of a visit? We just said overnight is okay, so looking like no. But let's say an adult child who hasn't seen their parent or relative for over a year comes to visit and wants to stay for a week. I'm just throwing that out. Josh's eyes opening.
I can think of a lot of non-COVID reasons I wouldn't want a visitor staying for a week. I would, whether you can prohibit it, I don't know, but I would discourage it just for a lot of operational and compliance reasons.
Anything else from CDSS on that?
And I think there's nothing that would prohibit it, but yeah.
For everyone's sake, perhaps.
As much as I hate to go down this rabbit hole, any adult living in the RCFE must be fingerprinted.
Right.
So you start to get into the question of what constitutes living.
Right.
And I apologize, I thought we were talking about the CCRC portion, so yeah, that would be a different story.
So sort of similar to that. How many people could be in a residence, room, apartment, condo at one time, given that we're open to vaccinated and unvaccinated people, and might the vaccination status of the visitors influence your answer to that question?
So there's no specific limit in the PIN. What I would suggest is we would want it to be based on the size of the room or apartment where they could still practice physical distancing. Now, they don't have to do that if they're all vaccinated, so you would need to evaluate that piece. But as a general rule, I would say we'd want to have as many people as could reasonably be in there and still physically distance. Keeping in mind, it starts to get confusing, the visitors who are from one household don't necessarily have to physically distance from each other, but they have to physically distance from the resident. So you picture the resident in one corner of the room and 10 visitors over here. If the room's big enough, I don't see an issue with it.
Another somewhat related question, how about birthday parties? And let's say they do it outside. Can people eat at the party? Somebody's having a 90th, an 85th. What are we going to do about that?
I'd say if you're outdoors, yes. I know we discussed that previously. The big question coming up right now is Mother's Day. And I believe that's one of the recommendations the department's comfortable with, is that they would do those celebrations outdoors.
And I think it also just stands to reason you would have your mask on without eating. We'd probably ask that people not blow on the candles on the cake if you're serving it to everybody else. Thinking of some things logically where we're not transmitting some, our particles, so to speak. So
we provide a fan with the cake and just fan them out quickly, and nobody's
the way wrap under the candle.
Although I guess the fan is moving things around too. Maybe just no candles or don't light them.
Having had plenty of birthday cakes blown out by 2 and 3-year-olds, I'm on board with not having kids.
Okay, so this is actually a nice follow-up to an earlier discussion we had, saying that Josh spoke highly, telling people to get the vaccine, but licensing wants facilities to accept people to return without the vaccine. Yet if somebody had a positive TB test, they wouldn't be able to come back. So why, if somebody's COVID positive, do facilities need to accept them back?
That's a great question. I got a little lost on the traveling from vaccinated to positive. I just want to make sure we're all clear. They're two separate things, whether you're vaccinated or whether you're positive for COVID. Being unvaccinated does not mean you're COVID positive. I'm sure we all get that. I just want to be clear. Accepting residents back who are COVID positive is a really interesting conversation. Part of the reason we've been doing that is there's a pandemic, and there was a point where there were no other options. When we were in our various surges we've experienced, a number of times, there was nowhere for people to go. There were no hospitals or SNFs. I mean, they were there, but they were full, and so residents had to return. I would say generally, if your local healthcare system is not over capacity, and you have a resident who is COVID positive, meaning they are requiring they need to be isolated, I would work with your hospital to avoid bringing them back if you can. not refusing. You can't use this as a way to evict someone, but I would generally avoid bringing them back. And what we're finding right now is most hospitals are very cooperative with that because they're not over capacity in most, I think in pretty much all areas right now. They're not over capacity. So we work with the hospital and explain this is a residential environment. There are other individuals that are at a high risk if exposed to COVID. Can we please keep that person until they get out of their isolation period of typically 10 days? And so I would work with your hospital to make that happen. There were times when that wasn't an option because of capacity, and we all did our best.
Okay, just a few more questions, and then we are going to move on to the APPs. This is a clarification point that I think deserves clarification. So it says one of the screening questions for a resident returning from a family visit is whether they took precautionary measures such as wearing a mask and physical distancing. Does this mean the resident needs to keep face covering if they go visit their adult child and grandkids, like they're in the family home? Do they need to keep their mask on the whole time they're there?
That's what we would encourage, yes. We obviously, you have no way to monitor it, obviously, but we would encourage that, yeah.
Yeah, I just thought we should make that explicit. That is what is encouraged. That's what's in the guidance. Again, we won't know whether or not people do it, but that is what is recommended. I guess I would clarify that if they are able to sleep overnight in a room by themselves, ideally they would open a window. And then what do you think about taking off the mask under that setting? Because let's say you go overnight, you're going to wear the mask for 24 to 36 hours consecutively.
Yeah, as much as we try not to split hairs too much because you can get into very complicated scenarios. If you're in a room by yourself in someone's home, there's really not a reason to have a mask on at that point. But so I think if they're going to be overnight, they would obviously remove it while they sleep or shower, things of that nature.
Okay, last one. Are there any restrictions in asking for vaccinations of visiting nurses, bathing assistants, and visitors, or is that a HIPAA violation? So in other words, when professionals come, people who are serving in intimate contact with residents, can they be asked for their vaccination status, just as a facility will know the vaccination status of their own staff?
Well, this is coming from a nurse, not an attorney, but I would be very hesitant to implement a vaccine policy that would possibly prevent a resident from receiving necessary medical care. So if they're on hospice or they have a wound or whatever it is that's being managed by home health or the outside provider, I'd be very cautious to say we're not going to let you come in because you now have a resident with a health need not being met. So that's ground I'd be very, very careful with. I could just see a lot of downside to that from a safety standpoint. I think what's quite possible, I'm going to do what I said I wouldn't do and try and predict the future. I think what we're probably going to see at some point is when masks mandates eventually do go away, which I know we're all looking forward to, I think it's very likely we will see policies that say, for example, if you're unvaccinated, you continue to wear a mask. We see that during flu season in the past. In many parts of the state, different health departments would say if you're not vaccinated for the flu, you have to wear a mask. So it wouldn't surprise me if that's the road we're headed down with those types of scenarios in the future.
Yeah, and I would like to just kind of tag on to that too, as well as that it's okay to ask. There's no allowance to require that someone give you their vaccination card, let you scan the vaccination card, or even see the vaccination card. So if there were concerns that raised beyond that, we would make sure that folks also looked at the PIN, that there are additional things that were also added in for compassionate care that are not necessarily associated with end of life issues, and that has to do with those kind of access to medical care too. So if there's a question that has to do with a specific level, again, I think it's something to reach out to the LPA on, to walk through if there's still concerns with a particular entity or a person providing a service in the facility specific to a resident, and whether that person's vaccinated or not.
Okay, so and there are just so many good questions, and I wish we could get to more of them. There are things like why can a client and visitor hug? Why can't they eat together? Because hugging is lower risk than eating with your saliva and your breathing, and if you're hugging wearing a mask. There are a lot of questions about what to do if a resident has a roommate, to which the best answer is if the roommate cannot be in the room during the visit, that's ideal, or if the visit could take place in another room. There is, even though I said we were going to move on, I think there's a question I came upon that I think warrants an answer. So people say they're seeing challenges with asymptomatic residents who are fully vaccinated and test positive for COVID. They're not willing to go into isolation, and is there another realistic protocol, or what can people do? And then I'll stop looking so that we really will move on after this.
Yeah, those are a real challenge, something we encounter from time to time. The first thing I would say is, as a general rule, positive is positive. If a person has a positive COVID test, we should treat it as COVID positive with isolation, unless we get other direction from either the health department or that person's physician or medical provider. We do not want to make that decision. So I'd be very careful that no one on this call as a provider, as a residential facility provider, you do not want to make the decision whether someone requires isolation or not. With that said, what I would strongly encourage you to do is to get in contact with your health department. What we're finding in these situations, we just had one actually today down in San Diego County, where a person tested positive, and then after a series of discussions with the health department and retesting, the health department made the decision that it was a false positive. So I would encourage you to get them involved and help you figure out what the appropriate plan is for that resident, but keep them isolated until you hear otherwise. If the resident refuses to isolate, that's something we've really from time to time been challenged with throughout the pandemic. You can't lock someone in their room, but what you can do is educate and encourage and remind and explain to them the situation. Let them know you're talking to the health department. You're trying to get some more information, and I often take it slow. Mrs. Smith, will you at least stay in your apartment for me tonight? And then we'll talk again in the morning. And you just, you take it one day at a time until you can figure out what the plan is after talking with your health department.
Yeah, and I would add that that's, if you have a situation like that where you have somebody fully vaxxed and they're testing then positive, we would definitely want to know that the local regional office for adult and senior care, we are tracking those cases, and Josh is right, the great majority are, well, actually all of them that I know of have come back that it was a false positive versus a true positive, but we would want to be able to help you and figure out a solution to help do the isolation if necessary, even for a short period of time until the testing can occur. And then we work with HAI and the local public health also in kind of providing some additional supports to do that testing and kind of figure out what happened there, especially on folks that are fully vaxxed.
And the last category that we were seeing was if a facility had been in outbreak around the time the vaccinations were given, some people had residual positives, and we know some people stay positive. That should become less of an issue. But another reason to pull in the public health department and your LPA. So now, with thanks for their great patience, we're going to move to ADP. I will get us started here. We just have a few slides, and then there are all kinds of really good questions, so we will make a big effort to get to your good questions. Next slide, please. So PIN 2121 was released on the 15th and offers some guidance and support. It also refers you to existing PINs that are still in operation and can help you sort out answers to various questions. CCLD wants to make sure you know that at no time have they issued guidance prohibiting adult day programs from remaining open. So that this is not so much about reopening, unless, if you chose to close, then you're thinking of it as reopening, but there was not a formal or official closure period. All COVID-19 prevention practices issued by CCLD are really designed to ensure that local communities can operate the most effectively possible, providing services to the people in their region of California. Next slide, please. This was really the same for people in facilities, but what we want to really emphasize is the rights of the client or program participant. Really, we should encourage participants to receive vaccines. It was very clear, and actually the data from even more frail, vulnerable older adults told the story. So there were some people who, in the vaccine trials, who were like people in many adult day programs, where the ages, went up to 75 or sometimes 85. And we didn't really know what would happen with the very frail and very old, but there were outbreaks everywhere, and now there are almost none in our nursing home facilities. So the vaccines make a difference no matter how old and frail. We also hear people saying things like, well, I have diabetes, so I shouldn't get it. Actually, if you have diabetes, if you're obese, if you have a chronic illness, that puts you at greater risk for serious illness and death from COVID and makes you the ideal candidate for the vaccine. We know the vaccines work in those people, and because the risk for getting sick and dying is so great, the benefits from the vaccine are actually greater than they are for a healthy 25-year-old, just to name one example. That said, participants have the right to refuse the COVID-19 vaccine, and you cannot require your program participants to be vaccinated. There is no mandate for licensees, volunteers, or facility staff to be vaccinated, and we recommend that they all be vaccinated. But all individuals, regardless of their vaccination status, must do all the same things: wear masks, practice frequent hand hygiene, and maintain social distancing. Now, some people will say, well, then why am I bothering getting vaccinated? Because the more vaccinated we all are, the sooner we will get to a point where we can all stop doing the masking, the hand hygiene, and the social distancing. Next slide. I think this is Josh.
All right, there's obviously, again, still wanting to be diligent about our COVID mitigation efforts. There are some, relatively, I think, simple things we can do to help be preventative, particularly as you guys are accepting clients back into your programs. With that theme of social distancing, physical distancing, we've been talking about a lot today. One thing we can do to help facilitate that is have separate entrance and exit areas. And this just helps to prevent people or minimize people crossing paths as they come and go from your building. Anyone who's entering should be screened for both symptoms, signs or symptoms, and exposure to COVID. That's something that we want to do for clients, participants, visitors, staff members. Anyone who's entering should be screened at least once per day. Obviously, if anyone fails that screening, as much as I hate to say it that way, if they have symptoms of COVID-19 or a known exposure to COVID-19, we would want to exclude them from entering the building or entering the program until they meet the appropriate criteria for either quarantine or testing, depending on the situation. If clients were in contact with someone who has COVID-19 and they are fully vaccinated, they do not have to stay away from others. They do not have to be tested. So this is yet another good reason to be fully vaccinated. If they were not fully vaccinated, they would need to stay away from the program, not attend services until after their quarantine period has ended, which would, generally speaking, be 14 days. From exposure, that could change a little bit based on whether they have symptoms or they are tested. Next slide, please. One of the things you might have to look at is reducing capacity to help facilitate that social distancing. Similarly to what we talked about earlier, the goal is 6 feet apart, but we're not walking around with tape measures. So you want to look at what can I do to reduce the crowd or the size of the group based on the size of your space, the size of your facility, and what would make sense to help accommodate that social distancing. It can help to stagger when people arrive. This includes both client, staff, and visitors. And so one of the things we often see with day programs is they may open or begin at a certain time of day, and that's when you get a large sort of influx of your clients arriving for the day. We may want to look at staggering that out. Number one, to facilitate physical distancing, but also because you're screening everyone. That wasn't in the past a part of our process, right? So as we're screening people upon arrival, we're going to need even a little bit more time to do that without creating, crowds gathering at the entrance. Hand hygiene should be performed by everyone when they enter. That can be done either using soap and water, or it can be done using a hand sanitizer. It can be helpful to cohort clients. What does that mean? What it means is we try to create groups or clusters of clients that participate in programs together, eat together, etc. The reason we do that is if you have someone who ends up being COVID positive, you're reducing the number of people that may have had exposure to that person. You're reducing the risk so we're not just mixing different groups of people every day. By dividing them into smaller clusters or cohorts, we can help to reduce the amount of potential exposure. What you would also do with those cohorts is you would assign staff to the cohorts. So again, instead of having exposure to different groups of people every day, I would be able to keep those individuals grouped as well as the staff members who may have worked with them. Finally, disinfect and clean frequently touched objects and surfaces. And this is something, there have been some recent CDC updates about the potential for spread of COVID on surfaces. We know it is, in terms of the various routes that COVID is transmitted, this is a lower risk route. It is still possible to be spread that way, and frankly, there's a lot of other good reasons to clean and disinfect your frequently touched objects and surfaces, not just COVID. There's other organisms out there that we have to avoid. So we would recommend that you do that at least once per day. And in the case of things like dining areas, we would do it after every dining service. So frequently touched objects, surfaces, door handles, doorknobs, handrails, desk surfaces, phones, anything of that nature that's frequently touched. And now I will turn it back over to Vicki.
Great, thanks, Josh. We wanted to be able to provide folks kind of just some quick links to get to some of the materials that kind of support the department's pens. And so the first one is the COVID landing page for the CDC. The second one is our own landing page for Department of Social Services, Community Care Licensing COVID page, and then the landing page for CDPH, which we tend to walk fairly hand in hand with. The last one is actually an easy cheat sheet because it's a link to all your county health departments. So if you need to find out what tier your county is in for any reason, it's actually just the easiest way to find your county. And then our final slide is actually to be able to open up questions. So I'll just repeat kind of what Dr. Aronson repeated on the first half of our call today. You can use the Zoom Q&A box. I see there's still some questions outstanding in there. If there's a question that's similar to what you're looking for, just hit that thumbs up and it'll give it a higher rank. A higher rank will take them in those orders. If you're on the phone and want to text a question, just text to CDSS to 22333. And once you join the session, text the carry rates apply, but you can text your question in that way as well. If you have additional questions that come up even after this call, feel free to reach out to your local adult and senior care office, or you can always email us directly at ccl-19info at dss.ca.gov. So if you can't see the screen, I'll repeat that. You can always email us questions also at ccl-19info at dss.ca.gov. Also, I know it was made mentioned earlier, but in the chat box, there is a link to a survey, and it's that survey that drives future topics that you might be interested in. So please take the time to fill out the survey. With that, I toss it back to Dr. Aronson to facilitate the Q&A on the ADP pin.
Okay, so there are lots of good questions. We will start with, for ADPs, when they resume in-person services, will they be required to have staff test for COVID on a random scheduled basis, as has been the case for facility staff?
So the testing cadence isn't different between residential and ADPs. They were both set at 25% of staff every 7 days on a rotating basis. So that theoretically it's each staff member once a month. So the answer to that question is yes, because that PIN that has that testing cadence in place would still be applicable today. There is anticipation that will change, but that is the current guidance today.
So it's not quite random, it's a quarter. Everybody gets tested over the course of the month. There's a lot about when clients go back. So why isn't there a written plan in place telling us what steps are being taken to get these clients back out in their groups and day programs? I guess, the current provider information notice is that. Anything else you want to add about that?
Again, and I know that we say this a lot, the department didn't issue anything that closed ADPs or made them inoperable. Therefore, the department will not be issuing anything saying that ADPs are operational again, because we didn't issue anything saying they were not operational. So what we did do, though, is because of the number of questions that we were receiving, we decided to put out the PIN that just lumped all of the guidance into one PIN specific to ADPs that would be applicable, that were already applicable to any licensed setting. I think questions outside of the licensing realm that may have to do with, I'm guessing more in particular, the regional center system should really be referred to the regional center for what their process would be for initiating the referral and authorization for the services versus the licensing aspect of the services.
Yeah, I think just given how many shut down, they're looking for guidance, but the current PIN is supposed to sort of bring you up to speed. There's a lot of information to read, so one suggestion that I've seen is to sort of write down your questions and then go to the appropriate PIN to get them answered. I know some groups are doing this in a group setting so that everybody doesn't have to do all the work. And I know some local health departments, such as in San Francisco, are working with centers to help them figure out procedures. So if they've been closed for a good long time, how do we start up? How do we do cleaning? How do we do distancing? What's different? What's the same? So your local health department may also have some resources that would be helpful to you. Let's see, is there a maximum capacity for day programs? You sort of spoke to this, Josh, but maybe do you want to reiterate that one since it got a lot of thumbs up?
Yeah, there is no set capacity restriction specific to COVID other than what the program would normally be able to accommodate. But again, we'd want to look at either dividing into cohort groups or adjusting program times to facilitate social distancing. So it's really a matter of looking at your physical space and how many people can be in there, but still stay 6 feet apart.
There's a question here about, does hand sanitizer need to be locked away, or can we have dispensers out and readily available within an adult day program? Unless there's a specific guidance, I guess I would say the times I think we need to lock it away are when we are afraid people will use it as a weapon or eat it. So if you have clients that will do neither of those things, I would say having it out would encourage them to practice good hand sanitation and make that easier to do. And it would also enable staff to role model doing that between activities and just at regular intervals. Anything more than that to add, Vicki? Okay, good. Let's see. So this is a question saying, can you have a day program call next time? Yeah, so we're trying to address that now. And I also heard earlier, and I don't know, Lilith, if you wanted to say this, but there may be some further things that require clarification. So we are aware of that, and people are working on it. So keep posing those good questions and letting us know when things aren't clear.
Louise, if I can add too, and just kind of plug a little bit for our sister agency, the Department of Developmental Services issued out the Disability Thrive Initiative, and they're having a series of trainings as well, and we participated in those. I know that the May 12th one that's being held, and I apologize because I don't remember what time it is off the top of my head, but on May 12th there is one specific to ADPs. We will be participating with some other folks from the ADP sector on that call. So for folks that are on this call, you may want to write down that date as well and jump on that.
And then I just wanted to reiterate what Dr. Aronson just said. We realize there are some kind of gray areas, lack of clarity for our adult day program providers. So please keep submitting your questions so that we can take them back and provide you with that clarification for a future date, whether it's a pin or a call or both, but we'd love to do that. Thank you.
And I actually can't tell which this pertains to, but maybe it's a good general question. When will licensing begin their annual checks? And will people be vaccinated when they're coming to do the checks?
That is a great question, and it does cross both sectors. The anticipated date for us to roll back into on-site inspections, at least today, that date is May 10th. We will be rolling out with a more abbreviated tool that is actually a domain called the infection control domain. If you remember prior to COVID, back in those days, they had rolled out the full inspection tool, and it had domains in it. This infection control that we're starting with when we return to inspections will become part of that larger tool once we, at some point, I think we're looking, probably 3-4 months out in actually resuming that level of inspection. So the plan right now is May 10th, adult and senior care will roll back out into on-site inspections. It will be doing the infection control domain. That's actually, it actually went out to stakeholders, had input back on it, and our policy team through Bullet Shop is making those refinements. We don't know the length necessarily it will take on site, but the plan is for that to be the focus. However, it does not prevent if someone were on site, saw other health and safety concerns, that we would take on our full responsibility for oversight and enforcement and monitoring. But May 10th is the date to answer the question.
Great, thank you. This one's pretty straightforward. Can we require COVID-19 testing for our clients? You cannot. You can encourage, but you cannot require. So here's one. Since the latest CCLD PIN says we need to offer programming to people who are or aren't vaccinated, what protection or parameters can we put in place to protect our businesses, staff, and of course other individuals in our day program? And we've sort of already discussed hygiene and ventilation and masking and spacing and And those are kind of the core principles. Is there anything anybody would like to add to those fundamentals that we all need to be doing?
I also think it's just really making sure that we're keeping up our guard. I think sometimes, it's great that we're in the place that we're at and our numbers are starting to go down. And sometimes it can cause us to just have kind of complacency, or we may walk out to our break and then walk back in and realize, oh my gosh, I forgot to put my mask on. So I think it's just always the gentle reminders of, keeping those things in place and realizing that we're getting there. We're not quite there yet, but we are getting there. And just remembering too that folks are returning, especially for ADPs. You may have staff returning that haven't kind of been in a work setting, and you may have to do a lot of retraining to get going. We've been doing this even at the department and realizing that our LPA is kind of just sharpening us on getting back in that group of what's, the ordinary kind of life versus a crisis mode that we've kind of been working in lately. So I think it's just kind of also recognizing those kinds of things and not losing our sharpness.
I was going to add a couple of things too. Just maybe going back and rereading those two pins that we mentioned. So 20-33 ASB, which does have a lot of information that you will find useful, and also the most recent one, 21-21-ASB. And then I also wanted to remind everybody about the mitigation plans. I think those are really important for you to complete and having to submit to the department for approval, that will also prepare you for if you had closed to reopen your site. So.
Great, thank you. And a slightly harder question, actually. What happens if somebody does get COVID and has been to the day program? What do programs do then?
So what I would, obviously the person who's COVID positive should not return to the day program. That's the first point until they're out of their isolation period, which is usually 10 days, depending on their symptoms. Report to your health department, report to licensing, test staff and residents in the day program. Generally, we're not, and this is again where you want to talk to the department as well as your health department. Going back to our earlier conversation, that fully vaccinated staff do not normally have to be tested following an exposure, but we would test all of the, I think I said residents, clients, in the day program. And then based on the results of those tests, we would possibly have to isolate more people or even consider suspending the services. But it's a little bit different, obviously, than an RCFE or an ARF, where we're going to have people isolated to their apartments and things of that nature.
Thank you. So this is sort of akin to one that we discussed for RCFEs and residential programs. For adult day program service users that are in a 3-to-1 ratio, so 3 participants to 1 staff, can they share the same vehicle to go on outings like they did before COVID? So the idea is they should be having social distancing in the vehicle. It may depend on the size of the vehicle available. You want to have the windows down for some ventilation. You want hygiene going in and coming out, and good wearing of masks. It's a little tiny vehicle, then technically you're not capable of doing social distancing, although I realize that may limit options for outings. Anything to add to that, Josh?
Well, I would almost view that group of 3 participants to 1 employee as almost like a cohort. And if we can keep the clients and employee groups consistent, so we're not, shifting people between groups from day to day, I would really view it as a cohort. And while you still want to do your best to socially distance and, of course, wear masks and all that good stuff, you're minimizing that potential for exposure to other groups. And if you do have a positive case, you should be able to keep it pretty well contained.
There is a question here about the testing. If if clients and staff have been fully vaccinated, do they still need the random testing every 7 days? So clients do not need random testing. Program participants do not need the random testing. The staff, even if fully vaccinated for the time being, should be tested so that within the course of a month, each staff member is tested at least once. So that must continue. So this is kind of a variation. It's, can day programs pick up clients for outings? It's sort of related to the one we were just discussing. I suppose if you could put them in a car for other reasons, you can, but you've got to do the social distancing, the hygiene, the mask wearing. So this is interesting. So again, speaking about the governor's June 15th reopening with awareness of Josh's earlier caveat that who knows what the next 2 months will bring. So let's say, I guess the question fundamentally is, can we expect day programs to fully reopen then? And I think what the person means, fully reopen, max capacity, maybe we don't have masking or social distancing, the world is open and resembles the pre-COVID life to the extent that any of us can remember that.
Yeah, and again, I think it's the similar answer we've given. We're just not there yet. We are still wearing masks, we're still physical distancing, and all the best ways you can accommodate that in your setting. We're not at the point that we are just sort of flinging the doors open and removing all those protocols.
Okay, so this is a little bit more about adult day healthcare providers. So in the absence of specific guidance for them, they're being referred to DSS guidance, but it's a little unclear because DSS is mostly about non-health, is about non-health sites, what to do about distancing and hands-on personal care assistance, for instance, with therapy and nursing interventions. I'm going to guess that this resembles assisted living care, but I will leave it to the CDSS or Josh to comment.
Yeah, I mean, obviously, if we're having to provide hands-on assistance to a client, we can't practice social distancing while we're doing that. So that's where we make sure our staff are wearing their masks, they perform hand hygiene before providing that assistance. Depending on the level of assistance, they may be donning other personal protective equipment, if they're assisting with toileting, for example, or personal care. But it's understood that in order to perform that service, you're going to have to get close to that individual and not be able to maintain your physical distancing.
Sorry, there are a lot of questions and some redundancies, so I'm going through as quickly as I can. So this is a good question. Can we fill in the responses to the PowerPoint questions and make it available on the CCL site? We do obviously have the answers. The reason we didn't provide them, which is not usual for us and perhaps frustrating to you, is that everything was changing so quickly and we have to submit them for a variety of approvals, etc., and we wanted to be sure to give you up-to-the-minute information. But what do you think about that? Can we fill them in with our answers and post them, or we will have the recording posted so people who want to know the answers can actually easily listen to the beginning of the recording. Anything from CCL about posting? Any thoughts?
We'll take it back and see if we can do that and get it posted up. I think we dropped the link to where the recordings are in the chat. I know that was one of the questions also that was coming up in the queue.
So here's one, a person who runs an Alzheimer's Day program. They have to serve a lunch and 2 snacks. How should they make sure participants are safely eating their meals?
Residents, clients, with Alzheimer's or other forms of dementia or cognitive impairments, for that matter, are obviously among the most challenging when it comes to implementing all these various COVID protocols. So, as much as I hate to sound overly simplistic, the reality is you do your best. It's not going to be perfect. Your residents with dementia are not always going to remember or comply with staying 6 feet apart from one another. Hopefully they're vaccinated. That obviously protects them significantly. Again, think about things like dining in smaller shifts. So depending on the size of your day program, if you previously had everyone dine all at the same time, you might think about dividing that into 2 or 3 groups so you could have them spaced out a little bit further while they're eating. Assist them to perform hand hygiene. Sometimes we forget that while there is, of course, the potential for transmission through airborne route, what also happens with a lot of things like COVID is you get those bugs on your fingers and then you touch your face or your mouth, and that's how you end up getting sick. So I say that as I'm leaning on my hands here. So often demonstrate, go to the sink with your resident and wash your hands as they wash their hands, do a lot of that kind of modeling. Same thing with masks. Your residents with dementia are going to have challenges with masks. Encourage, remind, model if they see you wearing your mask. That we find that that's often helpful. But again, it's like anything in dementia care, as you guys know very well, it's just not always perfect.
Ventilation can also be helpful if you're in a place where it's neither too hot nor too cold, which I guess if the program's opening in June, too hot is more likely unless you're in the city of San Francisco where you might be freezing. Ventilation is good, and in addition to that, and any sort of filters for the air can be helpful as well. This is a really good question that is mostly just an FYI, but the person says they appreciate the PIN communications very much, but they've been getting longer and longer, and the suggestion is, could there be like a Reader's Digest version, or could there be versions that acknowledge that maybe you're a 6-bed versus a 300 bed or something to make it easier? The person writing this says they work 14-hour days and it's just a lot, and they keep feeling overwhelmed and having to review it because it just it's not the kind of information or presented in a way that sticks optimally. So I think that's some good advice that I wanted to read aloud. Let's see. Yeah, so this is akin to what we discussed before. Should new clients to adult day centers be tested for COVID before starting? Sort of a variation on should they be vaccinated before starting? Thoughts on that? Requiring testing before the day program?
There's always the recommendation that it's the best practice, right? I think it falls back to the same as the vaccination. We probably wouldn't want to go down the road that someone would not be admitted to a day program, whether for lack of vaccination or lack of COVID testing alone. But I do think it's good practice.
But also, just if you think about it clinically, to me what's a little bit different with an RCFE or an ARF, another residential facility compared to a day program, we are testing people before they move into residential facilities, and that's in one of the pins. The difference is that that's where the resident's going to live. And while they may come and go, they're primarily in the facility. Whereas at a day program, by its very definition, they come and go every single day. So, a testing before they start the program, there's no downside to it, of course, but I would just keep in mind that you can test today and get COVID tomorrow. So I'm not sure it's as helpful from a clinical standpoint in a program where people come and go every single day.
There is a question here about whether DDS and DSS meet so that the two are on the same page. So I'll hand that to Vicki.
We actually do. We meet on a weekly basis, and we've really been trying to walk hand in hand through this as best as possible, so that there's not deviation in our directions coming back and forth. And so, for example, the PIN for specific to adult day programs, we have DDS review that in draft form and take their comments and input prior to release, and they tend to run issues by us that would affect the licensing component. So we try to walk hand in hand as best as we can, and we've been doing that through the pandemic. So I'm hoping that folks aren't falling where there is confusion between the two. And it's good for us to hear the questions, because if that is happening, we would definitely want to know, so that we could try to do our best to fill that gap and not have that barrier between the two.
There's a question here about going back to using multi-touch pictures on tables again and drink stations. I'm thinking not.
Yeah.
Any yeses on that?
We're still trying to avoid multi-use items in food service. I think it's a relatively simple ask, so we think that's still a best practice. Unless you feel like you can clean and disinfect them after every use, which seems impractical.
What about allowing into day programs people who can't wear a mask for medical reasons? And I guess one could say whether they are vaccinated or unvaccinated. What does a business do about that?
To me, the answer would be very similar to the conversation we had about our residents with dementia. There's going to be times when someone can't wear a mask. You think of someone with severe COPD, for instance, it causes shortness of breath. I would encourage you to really, to the best of your ability, confirm that mask eligibility, as opposed to someone just saying they can't versus confirming that it is medically not practical for them. But in my mind, that would not prohibit them from participating in the day program. I think it would emphasize the importance of all the other measures, particularly social distancing for that individual. But I don't believe you would be able to prohibit them from participating based on that.
Great. Here's someone who says, while the department did not issue a closure notification to ADPs due to the restrictions of the residents, they had no choice because, at least in this case, many of their clients live in licensed homes. Now that restrictions are lifted, will they be able to return to day programs? Absolutely. The answer is yes. And they're sort of asking, why are homes allowed to take them on trips out of state, such as Las Vegas, but not allowed to return to the program? I think if we had our preference, we would rather they go to the day program than to Las Vegas. So clearly they did not consult with us prior to making that happen.
I'd actually rather that they go to some place of their choosing. So if they're choosing to go to their day program, then that's where they should go. And it's regrettable almost for me to hear that if folks were not exercising their right to actually leave the facility. That's something we probably would want to know about.
Yeah. I guess I was just thinking it's hard to imagine people in Vegas obeying masks and social distancing, but that may be my personal bias, so I apologize. You're right. The resident should do what the resident wants or the client. So we'll just take a couple more questions before we stop. What about school-age group home residents going back to school? How is that being managed?
I would, my thought would be the same as any of these other outings. Assuming they're able to go back to school. Schools have a variety of their own protocols in place with masks and distancing and so forth. So we would treat it like any other outing, where we would screen them upon return and not quarantine as long as they've not been exposed or have symptoms.
Great. Do ADP staff have the right to refuse testing? So if they don't want to be part of the 25% regular testing?
What we've been following is if staff refuse to be tested, they would have to be removed from the schedule until they agree to be tested. You want to be very careful with HR stuff. This is not an HR advice webinar. So don't go terminating people or things like that until you clear it with your HR advisors. But they should not be in the community if they're not complying with the testing requirement.
All right, so sort of towards the bottom of the list, we have a few questions about PPE.
Louise, can I add on to that real quick?
Oh, sure.
You may have some folks on this call that maybe haven't been on calls before. And I just want to reemphasize the thing that you actually always tell the community, and that is that part of it is also finding out why they're not comfortable doing the testing, just like we would want to find out why they're not comfortable doing the vaccine, and kind of walking through that process with them so that we can try to bring their confidence level a little bit higher on getting the testing. So if it's access to testing that the program is having difficulty with, or that staff member is having difficulty with, and you need additional resources or guidance as to where they can get testing, again, please reach out to the LPA. They can help walk you through that process because we've probably been having a lot more questions from the residential side and accessing those resources, and now it's kind of coming back through the ADP side. We can help walk through that process as well.
We often find it's things like they can't find time when the sites are open because they have two jobs, for example. So sometimes giving them an hour's leeway so that they can get somewhere between jobs to get tested. I mean, basically you need them to work and they need the job. So having that conversation, you're right, is really important. And there may be anxiety related to the test and the consequences of the test results, but there's also going to be anxiety related to not getting tested and not being put on the schedule. So having a sort of honest, asking open-ended questions type things. Yeah, like I absolutely respect your decision, and can you tell me a little bit more about what you're thinking and feeling? Something like that can go a long way. A few other mask questions or mask and face covering questions. Can a person wear a shield instead of a mask? And what about masks with valves? So maybe Josh, you want to take those?
They definitely should not wear a mask with a valve. That does not comply with CDC recommendations. We have not generally recommended face shields in lieu of a mask. That's not consistent either with CDC recommendations. We have had a few, and I'd be curious to get Dr. Aronson or Vicki or anyone's take on this. We have had a few situations where someone could not wear a mask, going back to that earlier question, because of medical reasons. But they were willing or able to wear a face shield, and so we worked with our local health department, and they agreed with that given the scenario. But those were very unique situations, and I count them on one hand how many times we've done it in the last year.
Yeah, if you kind of think about it, it makes sense. So a mask, especially one that fits well, will keep all your breathing from going. Whereas a shield, things that are going straight forward might hit the shield, but a lot of your breath and the potential virus within it can go below, it can go to the sides, it can come out, so you're still getting more into the air. Is it probably better than nothing? Yes, but it should be a last option. Similarly with the valves, people think, well, why are there so many masks with valves if I'm not supposed to wear it? Well, that's really more about, say, when we have fires and we have smoke. so that we can, breathe out, but it's keeping us from breathing in. It's sort of a one-way valve, so it's keeping us from breathing in all the smoky particles, but our actual breath is going out into the atmosphere. With COVID, if we have COVID, we don't want to be breathing out and giving it to other people. So that's why we don't want people wearing those valve masks, and why also initially, particularly here in California, there were so many valve masks available, because we keep having wildfires too. So there are many other questions, lots of fantastic questions from all of you, which we really appreciate. But I think we need to wind down. I hope we got to a reasonable distribution of them. And apologies if we did not get to yours. And I will hand over to Vicki to close us out.
I don't know if we have another slide coming up or if I'm just closing us out. So why don't I close us out? If a slide pops up, we'll do that. I can't say thank you enough to both Josh and Louise for really letting us utilize their brain power in this, their insight, working on the floor and in the field both. And also to you, the providers, both residential and ADPs that are on the line, and other stakeholders and interested folks, just for spending your time with us, the quality of the questions that you always pose. It gives us food for thought in moving forward, and gives us an idea of how we need to just make sure that our PINs are addressing those kinds of questions as best as possible as well. And so with that, I thank you once again. If you still have questions and they didn't get answered somewhere in the mix, please don't hesitate to reach out either to the local office or to email us at cclcovid-19info at dss.ca.gov. I almost forgot our email address. Again, the survey is still in the chat, so if you would take a moment and really give your input back on that survey. There was quite a number of you on the phone today. That helps us identify topics that are of importance to you, because that's what these are about, is making sure that we're hitting topics that really are what you want to hear. And so I just want to thank both of our presenters and all of the folks that were also behind the scene from UCSF and from the department in making this happen today. I bid you all farewell, and we will catch up next month with one another.